So thank you all for being here today. My name is Charlie Hoy-Ellis. I'm assistant professor at the College of Social Work, and I particularly want to thank the University of Utah Center of Excellence in Women's Health. So I'm going to start out my talk today on over the rainbow, health disparities and health equity among sexual and gender minority older adults. I'm going to really briefly talk about language, step into health disparities, which will signpost a path towards health equity and what we can do to move forward in terms of promoting health equity for sexual and gender minority older adults, which the National Institutes of Health has officially designated as a health disparate population for the purposes of research. And I've been using this, although I used to use lesbian, gay, bisexual, transgender, but then there's the whole who's being included, who's being excluded through language. So SGM, sexual and gender minorities, includes LGBT. It also includes two-spirit people, queer people, intersex people. It also encompasses those with same-sex or gender attractions or behaviors who may still identify as heterosexual. So the American population is aging rapidly. 130 million currently aged 50 and older, 4 million of whom identify as sexual or gender minorities. Number is estimated to nearly double within the next 9 years. So this is an example of a health disparity that sexual and gender minorities experience. So we compared population-based data. So we compared lesbian, gay, bisexual adults age 50 and older to their heterosexual counterparts. And as you can see here, 1 in 4 LGBT older adults experiences significantly clinically significant depressive symptomatology and or psychological distress compared to about 7% of heterosexuals. Other health disparities include cardiovascular disease, high blood pressure, diabetes, disability, obesity, asthma, subjective cognitive decline, and many others. The more we are doing research. So often when I'm doing a talk like this or going to a program or agency to do a training about culturally sensitive practice with LGBTQ or sexual or gender minority older adults, I often hear, well, we treat everyone equally. And, that's great if the playing field was equal. But as you can see in this graphic here, the playing field is not equal for everyone. Some people experience barriers to health equity. So health equity is this idea that everyone should be able to enjoy the best health possible. And so in order to do that, there needs to be equitable access to healthcare services, social services, things like that. And so a health equity perspective says we need to identify what those barriers are that are preventing people from achieving health equity or the best possible health that they can achieve. So these health disparities, these differences in outcomes at the population level, when we talk about health, we're typically only talking about the tip of the services, health services. So we're not really talking about the values, assumptions, beliefs, cultural aspects, social aspects, gendered aspects of these upstream determinants of downstream healthcare outcomes. So most of us experience what are understood to be general stressors. So these are things like unexpected ending of a close relationship, unexpected job loss, serious illness, things that most of us will experience at some point in our lives. But sexual and gender minorities experience additional minority stressors on top of these general stressors. So there's actual or anticipated discrimination and victimization. This can be acute, like experiencing a hate crime, or it can be chronic condition. So living in an environment that is not necessarily supportive or affirming sexual and gender minority identities and orientations. More internal to the person is this fear of rejection. So if my sexual or gender identity becomes known, people, especially important people, so friends, family members, loved ones, employers, things like that, may reject me. And so in an effort to escape that potential rejection or discrimination, sexual and gender minorities may camouflage themselves. This historically has been known as hiding in the closet or concealing one's sexual orientation or gender identity. And then there's internalized stigma. So this idea that we've all internalized the dominant culture's prevailing attitudes, stereotypes, and beliefs about marginalized social groups such as sexual and gender minorities. And then that stigma is targeted towards the self. So these all are chronic stressors. So you've got your general stressors and then your minority stressors that overactivate and chronically overactivate the HPA axis, which ultimately leads to accumulated wear and tear on the body, what's known as allostatic road. So you've probably seen an actual or a picture of an old dilapidated fence that's been out in the pasture for decades and decades being exposed to the weather. So it's gray and falling apart and everything. So that same thing happens to our bodies as a result of this chronic overactivation of the stress response system. So my research has shown, and others' research has shown, that long-term concealment of one's sexual or gender identity significantly increases the risk for psychological distress, as does internalized heterosexism and comorbid chronic health conditions. And even low levels of psychological distress significantly increase the risk for premature morbidity and mortality. So we took Myers Minority Stress Model, we embedded it within a life course, sociological life course framework and a developmental psychology lifespan framework. So typically when we are talking about health, so there's physical health, mental health, so these are some key health indicators. And then when we're assessing people for healthcare or healthcare access or healthcare conditions, we typically look at these adverse and health promoting pathways. So what's your diet like? Do you exercise? Do you smoke? Do you drink excessively? Things like that. We also look at social and community supports and structures. You'll see here the phrase identity management. This is a fancy term for this idea of camouflaging or concealing one's sexual or gender identity. And I also talked just a moment ago about higher cortisol levels and allostatic load. But we typically don't think about our people's intersectional identities, and that what happens earlier in life continues to reverberate throughout the life course. And we typically don't look at these multi-level contexts, these structural, institutional, and individual levels of social exclusion, marginalization, stigma, microaggressions, discrimination, things like that. So all of these things are working in tandem to get us to these health outcomes. So we can intervene anywhere here in the way. I'm going to suggest one small place we can intervene that's going to have lots of positive long-term consequences is here at the structural and individual level of discrimination and victimization. And so jumping back for just a moment to that life course context. So what happens earlier in life continues to impact us throughout our lives. So today's midlife and older adults were born in an era, so until 1973, homosexuality was by definition, American Psychiatric Association's definition, a sociopathic personality disturbance. At the same time, sodomy or any sexual activity not specifically designed for procreation was illegal in all 50 states. In 1963, Illinois became the first state to decriminalize sodomy. It wasn't until 2003 that the US Supreme Court struck down the remaining sodomy laws in the United States, at which time same-sex sexual behavior was still a felony in 17 different states. And being arrested on such charges, it's not just the arrest, but your name, your phone number, everything's printed in the newspaper. So people would actually lose their jobs, their families, and have to move to a new place to live. So many midlife and older adults will hide who they are, conceal who they are, camouflage their sexual orientation in order to avoid harassment, discrimination, isolation in healthcare settings. And this has actually been documented that this actually does happen. But as I pointed out, going back into the closet to safely access services further increases mental and poor mental and physical health outcomes. So we know that 1 in 5 sexual and gender minority midlife and older adults are not out to their healthcare providers. And so this can result in suboptimal or poor healthcare in addition to those long-term consequences of concealing one's identity. I'm not going to show these two movie clips because whenever I show a movie clip on Zoom, it kind of gets wonky. But if you ever get the chance to see Gen Silence, a documentary that follows the lives of 6 LGBT older adults in the greater Boston area as they navigate healthcare and social systems. And then Southern Comfort is a documentary that follows the last year of this man's life. The reason it's the last year of his life is he was seeking treatment for a diagnosis of ovarian cancer, and 20 different providers refused to see him because they were concerned about how other people in the waiting room might feel uncomfortable. By the time he found a physician that would treat him, it was already too late. The ovarian cancer was inoperable. So, what can we do to move health equity forward for sexual and gender minority midlife and older adults? So, typically, when we think about intervention and prevention, what about educating ourselves? So, what does our practice setting look like? What do we understand about the social determinants of health for the people who are coming to us seeking services? Does your practice setting engage in community events? So, for example, the Jewish Family Services collaborating with Utah Pride Center because they recognize, hey, we have midlife and older Jewish sexual and gender minorities. Maybe we should think about serving them also. Letters to the editor can be powerful. Contacting representatives. We really need to get the Older Americans Act uh, adjusted so that sexual and gender minority older adults are formally designated most vulnerable population so we can direct more funding towards their health and social care needs, as well as the Equality Act. It's still uh, legal to fire someone or deny services, healthcare services, public accommodations, things like that, based on sexual or gender identity in half the states. So here in Utah, we have SAGE Utah Service and Advocacy for LGBTQ older adults. I'm not going to click on the link here, but here is a link. Just go to utahpridecenter.org and click on senior programs, and you'll be able to see the amazing, amazing work that SAGE provides for our midlife and older sexual and gender minority or LGBTQ population here in Utah. So coming back full circle, when I walk into your place of practice, your healthcare provision, your social services provision, do I see myself represented? Do I see anything like this anywhere in your waiting area, in your lobby, whatever, that tells me that you recognize that sexual and gender minority people are part of the population that you serve? And by saying that we treat everyone the same, you're actually continuing to marginalize LGBTQ older adults. But if you recognize that pride comes in all ages, that LGBTQ people and their caregivers also experience dementia-related issues. If I see a magazine on the coffee table or the end table about understanding issues facing LGBTQ older adults, the message I'm getting is that I'm recognized, I am seen, and people know that I may have specific needs. So if I see myself represented, I am more likely to disclose my sexual orientation or gender identity, which is going to help my mental health, but it's also going to support the provider in providing the best services possible. So I want to thank you all very much for allowing me this time today. And I believe that we now have a short Q&A period.